and the values of the old country were very important in their interaction with their families and their conflicts and people within the family who were more or less acculturated than they were. And sometimes the historical changes have been so huge that you can get cultural individual differences, things that where the history may have changed either before you were born or early enough in your own life that you're not aware of some of the issues that the elder client brings in. Like, there's still a lot of African American elderly who remember the segregated South and the pre-civil rights era in the United States and overtly express day in, day out racism and segregation and discrimination at levels that most of you don't remember it. Even those of us who don't remember it can only cloudily remember it. These days, if we were directly affected by it. Same way for like gay and lesbian aging, whether you were born and raised pre or post Stonewall has a major effect on how you think of being a gay and lesbian person, how that plays out in your life, the level of discrimination that you may face. And I think, there's a level of discrimination on the basis of sexual orientation that still plays out in age-segregated settings in our society that you wouldn't see in your age-segregated settings. So older adults are much more discriminatory about sexual orientation than new people tend to be by multiple factors. The inner context circle is more about just the specific social context of particular older adults that you're seeing. So what ongoing discussion I have within psychology is a lot of the psychologists who focus on working with aging are particularly focused on working in nursing homes and other long-term care settings. And one of the discussions we have about it is in order to do that work, a lot of the expertise you need is the expertise of the context. And some of them actually know very little about the nature of aging and older adults who are not in long-term care. And it's an important part of their training and their larger context to understand that what you see in long-term care settings is not normal aging. And this is a very selective part of our just as people who are going to go into long-term care settings need to understand the social ecology of long-term care and the ways that those social structures and social rules and regulations can create some of the psychological problems that you see there, that you have to learn to work with staff and negotiate with staff and train staff in order to change some of the patient's problems and behaviors. Actually, on a more mini level, that's a good example of what Felicia was asking about earlier. Society-wide kind of throws me as how it's possible to do these kind of things, but within particular nursing homes, and sometimes within the whole nursing home change, you can do more community-level interventions that have an effect on all the patients in the nursing home, change the whole nursing home environment. The inside, as you've learned, there's both positive and negative aspects to development across the lifespan. And then the interplay of the other boxes on the inside. My specific challenges, what I focused on mostly is thinking about chronic illness and disability of all kinds, grief for the loss of loved ones, and then caregiving relationships, each of which I think in themselves has special content, knowledge, and sometimes specialized skills that you need to deal with those particular problems. And I think it's really useful to think of those challenges as being probabilistically associated with older adults, but certainly not unique to older adults. And all of those cases are literatures that involve younger adults as well as older adults. And we've talked about off and on over the semester sometimes interventions and rehab strategies and whatnot that we know about with younger adults that don't get translated into the older adults.
So those be things would go on that specific
The
challenge.
specific challenge.
Chronic illness,
Yeah.
breathe, caregiver.
Exactly. And then they can influence both the presenting problem. One of the things I found myself saying a lot, teaching people about therapy, is that once you know once you have the results of your psychological assessment, I don't think that the actual techniques of therapy with older adults are hugely different. I actually think it takes specialized training to get people to do the same things with older adults that they do with younger people. But, that's a much longer story. What you actually end up doing, if you do anything, is not hugely different. But getting that presenting problem straight is a much more complicated process because of dementia, because of chronic illnesses and disabilities, because of treatment, medical treatment effects and so forth. Assessment in older adults is more of a problem, and also because of the special nature of some of the specific challenges that older adults sometimes face, can make that presenting problem, sorting that out can be much more difficult. And then the other thing that I think is affected by all of this is the therapeutic relationship. To find that even though I don't think the therapy should be all that different, that people often find relating to older adults really different. And people who have spent their lives, people who don't intentionally decide to work with older adults, but sort of find themselves growing into an aging practice or switching into an aging practice later on, or find that life randomly throws them into an aging practice, often have real issues just relating to older clients. and seeing older clients as changeable and seeing younger clients. Probably the most common boneheaded mistake that people make in doing therapy with older adults is not doing active interventions with older adults. If they know what they would do with a young person, they don't just do it with older people.
Is that true even though they're aging with their clients?
Oh, yeah. I've not found age of therapists to be helpful. And I don't know if this would still be true. Early in my life, I often found it to be unhelpful. Although I think some of the reasons for that were bad administrative decisions rather than anything intrinsic about the age of the therapist. In organized care settings, it's not uncommon to decide that if you have an older psychiatrist, psychologist, clinical social worker who's sort of screwing up and not doing very well, let's have them work with the old people. The worst example I ever saw of this is I went out to do grand rounds at a state psychiatric hospital once, and they had an elderly psychiatrist was the attending on the unit, and he was demonstrating a mental status exam with one of the clients, and he turned around to explain why the client's answer about the date was wrong, and one of the nurses pointed out to him that the client was right. And he not where you want to be. But I think actually you're kind of like they decided to put the demented psychiatrist on the dementia room. Yes, there's a certain kind of plausible ring to it.
Just they know the condition better.
It's been unlike, we had an inpatient unit psychiatrist in another setting who got caught with his hand in the medicine cabinet and got sent off for rehab. And when he came back from rehab, they put him in charge of the drug program.
Wow.
So, you can kind of see the logic, right? It's not a good idea. Yeah, this sort of immediate intuitive appeal, I suppose. Don't think about it very hard. The other thing I've seen happen with therapists and also in peer counseling programs, when the peer counseling programs didn't involve much training or ongoing clinical supervision, is that you can, and therapists can screw up in this way about clients of all ages, but it's just an aging thing in most of my concerns. You can get older clients who have dealt with some of the issues of late life, and they're very invested in having the